Okay, so we're going to talk next about intracranial pressure. So your brain is inside the skull, which is a box of bone. Okay, inside that box, there is an amount of brain tissue, there's an amount of blood, and the blood is blood flow, but that blood takes up space, and there is cerebrospinal fluid that also moves and takes up space. But that box can't change size once the sutures close in childhood. Okay, and they close in really early childhood. So any change in the volume of one of those things has to be offset by change in one of the other components to maintain constant pressure. So think about that box, and inside that box, you've got this much brain. Well, we can't change the volume of brain, right? I mean, we can, but that's not good. If we change the volume of brain, we're smushing the brain. Okay, so we've got a volume of brain. And then we have a volume of cerebrospinal fluid. That's fluid that goes through the ventricles and it circulates. And then we have a volume of blood, which is going, circulating through that brain tissue to provide oxygen, remove carbon dioxide, provide nutrients, remove waste. Okay. So if we get more of one of those things, volume-wise, one of those things gets bigger and takes up more space, then it decreases how much of the other things are there. If intracranial pressure is higher than the arterial pressure, then the brain doesn't get perfused. Think about that for a minute. We have arteries that are going through the brain tissue to provide perfusion for the brain. If the pressure in that closed box increases, that's going to decrease the amount of blood flow. If the pressure inside that box, the intracranial pressure, is higher than the arterial pressure, then that patient doesn't get any perfusion to their brain. That causes brain death. Now, if we have a baby and they have increased intracranial pressure, the fontanelles may be bulging, okay, and the sutures may widen because the skull actually can expand because those sutures are not closed yet. If we have that closed head, okay, closed box, if there's too much pressure, it shoves the brain someplace it shouldn't be. Now, the brain can be shoved if there's pressure on this side, say from a tumor, it can shove this hemisphere over onto the other side or part way. It can be, there's a lot of different ways it can be shoved. That's called herniation. And if you look, your textbook actually has, your IGE textbook actually has images of the different types of herniation. The one that anytime we have herniation, that tissue is being scraped against or pressed against bone, and it's potentially being damaged. But if there's too much pressure generally in the head, it pushes, the pressure is downward, and the way of escape is the back at the bottom of the skull, and the brainstem herniates down into the spine. Okay, that is fatal. Now, what causes an increase in pressure in the skull? Increased intracranial pressure. Something that doesn't belong there, like a tumor or some other lesion. So brain tumor, we've got tumor there taking up some of the space, so it puts pressure on the brain. Okay. Swelling, brain swells for some reason. An increase in cerebrospinal fluid. So we've got too much cerebrospinal fluid. That's going to be usually because it's not draining well and not circulating correctly. So increased cerebrospinal fluid. Bleeding. Okay, if I have an artery or a vein in the head that begins to bleed, that blood starts to take up space. When we talk about a brain bleed, the damage is You're not going to lose enough blood to bleed to death inside that box before you die from the blood taking up space that it shouldn't be. So if we have a venous bleed, most often that's causing just pressure, that increases pressure. Arterial bleeds, depending on where they're located, can be located in a place like an epidural arterial bleed can put pressure, causes pressure. But if there's bleeding into the cerebrospinal fluid, that actually causes other vessels to spasm and decreases perfusion. So when we're talking about increased intracranial pressure, we're talking about adding something else that doesn't belong. Something that doesn't belong there at all. Brain tissue gets too big because it's swelling. Increased cerebrospinal fluid or bleeding. Okay. What does it look like? So a baby that still has fontanelles open, it will be bulging when they're not crying, bulging at rest. The sutures may begin to separate. Okay. Also think about what it's going to look like or what you're going to feel like if there's too much pressure. They may have a headache. Well, someone older can tell you they have a headache. Someone who's not verbal or who is pre-verbal may not be able to tell you about that headache. So they may be fussy, they may cry, they may even scream, try to hold their head, bang their head against something because of that headache. They may be restless, they may be drowsy, and they can be both. Babies will often have a high-pitched cry with increased intracranial pressure. They don't feed well. If it's severe, there's something called the setting sun sign. Their eyes look downward to the extent that when you're looking at them, their eyes look like the setting sun. Let's see if we can find a picture of that. Okay, I found a picture of an infant that actually shows several of these. My guess, I don't know diagnosis, my guess is probably hydrocephalus. But you can see this baby's head is really enlarged because the sutures were not closed yet. And so the sutures reopen, that allows for expansion of the skull. If you could feel this fontanelle, it's probably bulging. But if you look at the baby's eyes, this is setting sun sign. Okay, the baby's, and the eyes will be in this position all the time. This is not just the baby looking down, they stay in that position. Someone with increased intracranial pressure may also have nausea, vomiting. They may have blurred vision or double vision. They may have seizures. Now, if that pressure gets higher, late signs, so severe increased intracranial pressure, bradycardia, their heart rate slowing down. Well, what's happened? What's causing that? Pressure on the brainstem. Okay. Decreased motor response to commands, so they can't move and follow commands. Decreased sensory response to pain, so they'll become less responsive on that Glasgow Coma scale. Their pupils may have alterations. Remember, pressure on a particular part of the brain can cause the pupil to dilate. Posturing. Cheyne-Stokes respirations, remember that pattern where it gradually increases, gradually decreases, pause, gradually increases, that Cheyne-Stokes. Remember that it's associated with end of life or neurologic conditions. So pressure on the brainstem can cause that. They may have papilledema, which is edema in the back of the eye that's visible with an ophthalmoscope. They may have decreased consciousness and then move into coma. So management of increased intracranial pressure, we want to decrease that pressure, right? So what can we do to minimize that pressure? So some providers go ahead and sedate and paralyze that patient and put them on a vent to decrease the pressure. We want to elevate the head of the bed, and we want to avoid their jugular veins from being compressed. So we want the head of the bed elevated, but we don't want them up so high they're doing this and compressing those jugular veins. We don't want their heads turned into funny positions that might, because we want adequate drainage. They actually can put in a ventricular drain. It's a drain that's inserted usually through a hole in the skull that goes directly into the ventricle to drain off some cerebrospinal fluid. and allow more space. For if there's a mass like a tumor or a hematoma from bleeding in there, they can remove that. If they have cerebral edema and it's pretty severe, an osmotic diuretic like mannitol or hypertonic saline may be given to get that swelling down quickly. Remember though that those rapid fluid shifts can cause a lot, are risky, and so that patient needs to be monitored closely. We want to maintain their PaCO2 at 25 to 30 millimeters of mercury. That means you're going to be getting frequent ABGs. Hopefully they've got an ART line in and we're not sticking them over and over for that. And they're going to be on a vent to keep their, or some kind of assisted respirations, usually vent, to try to keep their CO2 down. CO2 is high, it increases brain swelling. We want to avoid pain and emotional distress. We want painful procedures to be scheduled when that intracranial pressure is the lowest. So that drain can often measure fluid as well as remove some of the fluid, or it can measure the fluid as well as remove some of the fluid. So we want to be monitoring their intracranial pressure, and anything that's going to cause that patient pain, we need to do when their pressure is lowest. We don't want to have them already high and then we do something that makes them hurt. We want to minimize stimuli. We want to really try to avoid suction. If we have to suction to maintain their airway open, we want to hyperventilate them with 100% oxygen first and then use very brief suction passes, because that hypoxia may further increase their intracranial pressure. If someone has increased intracranial pressure, a lumbar puncture is contraindicated, because if we've got too much pressure here, somebody sticks a needle in near the bottom of the spine of the spinal cord or the middle of the spinal cord, that decreases the pressure, so that sudden change in pressure can actually cause herniation. And then a head to toe assessment can help us, may give us information that's helpful in figuring out what's causing increased intracranial pressure. So increased intracranial pressure is not a diagnosis itself. It is a symptom of a lot of neurologic illnesses. Okay, in the next section, we're going to talk about taking care of an unconscious child.